Good morning. Happy Sunday. So I have had quite a few updates when it comes to planning for the clinical semester this summer. So I am looking at summer 2026. What are we doing? What kind of experiences are we trying to get? And also thinking about the fact that this is the last clinical semester I will have until I am able to test and hopefully potentially start working as a provider while finishing the doctorate portion. One semester left after this for the master's degree. I have had so many big things happen. I'm sure I've mentioned this before, but I'm a first generation college student. My parents, my sister, they went straight to the workforce. My aunt was a nurse. That is kind of what inspired me to look into it and see the fact that you can do so many different things with this degree. So with that being said, I didn't really know what I was getting into for any of this, actually, any of it for federal student aid. That was a learning curve that I first experienced in high school, really of my own accord and out of necessity. My parents are great, but this was my responsibility, so they said, figure it out. And if you need information, we'll try and track it down. So that's how the associate degree went. But so much to figure out between student aid and registering for classes and communicating with advisors. My most recent hurdles have been, of course, planning for clinicals as a provider or as a graduate student. In your undergrad, it gets planned for you. As a nurse practitioner student, technically 90% of the time you're responsible for finding your own spots. There are schools that will help you. That's where I'm at. But you are still encouraged to look for sites. So let's go over what I've got planned for this summer because it's come from a little bit everywhere. First off, I have been emailing everybody. I live in Northeast Ohio. I have big hospital systems, Cleveland Clinic, Summa Health, Cleveland Metro, plus the local hospitals south of that. You've got Altman, you've got what was once Mercy is now Cleveland Clinic Mercy. Cleveland Clinic has bought a lot of the hospitals in Ohio, Canton, Dover, and random places. You've got Cleveland Clinic, you've got Cleveland Clinic Akron General, Cleveland Clinic Mercy Hospital, Cleveland Clinic Union, all the way down the line. We've got a lot of Cleveland Clinic. So a lot of big hospital systems, a lot of the bigger hospitals, not necessarily the satellites, have psychiatric units or inpatient mental health units, but the big hospital systems are a little bit more difficult to get into because they are teaching hospitals, so they have more residents. They have doctors coming in needing these placements. They have maybe nurse practitioners or nurse practitioner students who worked or work in those units that are already kind of set up. So those were off the table. I tried them. We've got Akron Children's Hospital, also they've got an inpatient child and adolescent psychiatric unit. So I went through all the emails with them and their contact people, their liaisons, and basically they're like, yeah, if you want to set up a time for 2027, 2028, we got you. We can try and pencil you in. I'm like, nope, I don't. I need to be done this summer. I don't need inpatient for this summer, but that's just a little taste of how reaching out has gone, specifically to the hospital systems in Northeast Ohio. We also have we've got the state hospital jobs. We've got the Ohio Department of, they just changed their name. They were the Ohio Department of Mental Health and Addiction Services. Now I think they're the Ohio Department of Behavioral Health, ODBH. We've got a bunch of hospitals in that system, all the way from Cleveland, Massillon, further south to Columbus. We have got private practices. We've got private practice, just general outpatient across the lifespan, nothing specific. And then we've got private practice specialties like ketamine, TMS, treatment-resistant depression, and sleep medicine, which we'll get into in a little bit. We've also got some crisis centers. We've got some community centers. Once you start digging, you will find that despite the fact that there's always a need for more mental health services, there's actually, if you look for it, a decent amount around this area. So with that being said, I've reached out to a lot of people. A lot of it has been time sensitive or things haven't lined up because of time frame issues. What I really need is child and adolescent psychiatry right now. I'm supposed to have 50 hours and I got approximately 10 hours in my first rotation because we had a handful of patients that were fairly young, like 10 to 15. But it definitely wasn't the highlight of that first clinical rotation. So I could definitely use more experience. I don't know how much I want to work with children, but I think it would be good to understand the idea behind it and what that might look like, just in case, because you never know what's going to happen. So then I think I mentioned that I see a PMHNP for some anxiety symptoms that had reared their head after working in the ICU through 2020, and I still see her. And hopefully I've been an easy patient for her. I've been pretty stable on our current regimen, so take that how you will. But she did mention she's got her own LLC. She moved from a community-based site to a private practice that she owns, and she has got one partner right now, and that partner has taken on 2 students for the summer, but it sounds like it's pretty flexible scheduling. She had mentioned possibly doing hours at her site, and at first it was just with her partner, and then she, at like 2 appointments ago, she mentioned doing clinicals with her because she does have some child and adolescent patients. So I finally thought about it, and she was a hair intimidating, I think because she is my prescriber. She knows my history. I go to her as an authority figure, as a provider. So the thought of going in as her student and making decisions for some of her patients and throwing back and forth ideas, it was a little intimidating. It was a little, what if I don't live up to her standards? I know she's a good provider. But college is just getting over your fears. So got over that fear, and I emailed her and I said, hey, all right, I am down. If you meant it, if you still can accommodate it, I would like to do some hours with you. Let me know a good email address I can send to my college. And I had an appointment with her maybe a week after I sent that. So she just waited to address it at the appointment. And she said, hey, I got your message. Yeah, absolutely. You can use this email, send it to your school. You can do time with me if that's all right with you. I said, that's fine with me as long as it's fine with you. As my provider, I don't know if you want me seeing your behind the scenes. You have a certain way of thinking. You probably have a certain way of dealing with patients that get under your skin a little bit. And I understand that. As a healthcare professional, we are not perfect. We try and stay professional, but there is a behind the scenes. As long as you don't mind me getting behind your scenes, absolutely, I'd love to do some hours with you. It's a beautiful office too. Like, I would love to spend some time there. I sent her information to my school, and I'm awaiting confirmation on that one. I need to make sure it gets to the right people. I sent it to the person who typically directs this process, and then I CC'd in my advisor, and only my advisor responded and said to make sure I send it to the person who does this process, who was also technically in on the email. So I'm not sure why I only got a response from my advisor, but I guess I'll make a separate email and just say, hey, this is the information. I think there might be a form to fill out. Typically, I just have to send an email and the school will follow up, but I'll go ahead and fill out the form this time and make sure everything gets done. So I plan on doing at least 50 hours with her. Hopefully, she said that she should be able to schedule some of her patients so that the child and adolescent patients are kind of blocked into certain days so I can get those hours in, which would be so helpful. But besides that, I have gotten 2 emails from my school. I keep wanting to say the name, and I know it's shown up at least once on a document that I presented, but I'm still not ready to just say it out loud. Just in case they don't like the association, and most businesses don't. So my school reached out to me on 2 separate occasions with 2 separate potential preceptors. And the first one, it says, please reach out to Dr. So-and-so to schedule an interview for potential clinical placement for your upcoming rotation. So a couple things with that. One, it is a doctor, it is an MD, it is a psychiatrist with medical training. I have no problem with that. I really think I will enjoy learning from that perspective, but sometimes you see it the other way where they don't expect as much from you because you're not a doctor, you don't have medical training, you're a nurse with an advanced degree. So we'll see how that goes. The other thing about that email is that schedule an interview. So it's not, hey, we found someone for you, reach out and confirm your placement. It's, hey, get a hold of this person, schedule an interview to see if you're a fit as a student for this person. So I did that, and I was scheduled to meet with her. I think I got a hold of her on a Thursday, and we set up an appointment for the following Wednesday. I was so nervous going into it. So I don't know if she's double board certified or if she just has a specialty that she works within, but she is a psychiatrist that also treats sleep disorders. So there's definitely overlap. Not only do we see it in the actual DSM diagnoses, we've got anxiety, you may see trouble sleeping. If you've got depression, you may also see trouble sleeping or sleeping too much. Sleeping is a huge question in psychiatry. How's your sleep? How much are you getting? Are you having trouble falling asleep, staying asleep, nightmares? What's going on with your sleep? So she has overlapped the two, and she has very much so specialized. She does Inspire implantations, which is an implantable device for sleep apnea. I'm very curious to know how that goes and how that plays out in her day-to-day. She does CBTI, so CBT for insomnia. She does TMS. She does Spravato or ketamine therapy. And it sounds like she likes to get to the root of the issue, because maybe if we treat your sleep, we treat your symptoms. So I went to that interview, very nervous that I was going to get like tested on sleep medications. So I was studying all of my everything. I was studying everything: melatonin, Remeron, trazodone, the Z drugs, Ambien, the newer, I don't know how new they are, but newer orexin medications. I was looking through all of that. I was trying to study up on sleep apnea or OSA, which I have a good foundation in based on my ICU experience. That can really go south when it's untreated. So I was preparing, and I went into this interview, which the location is an hour away from me, which is fine. An hour is doable for what I need. And the interview was 50 minutes long. I was not prepared for that. What do you talk to a stranger about for 50 minutes, especially when you don't have anything in stone? It's not like, I am your student. Let's talk about your process. I want to hear about No, it's kind of like, are you going to accept me? Like, at several points in the interview, I was just kind of waiting like, so? And? Are we on? Are we doing this? But it was a little bit of, tell me about your history, like work history. Tell me about your clinical rotation so far. What have you been doing? How have you been doing this setup? How do you expect this setup to go? I'm her first student, which is a trend that I have had my entire graduate career so far. My very first clinical, I was definitely the first student that they had at the clinical site, and I'm pretty sure I was also my preceptor's first student. She had worked somewhere else prior to that. But so we were just figuring it out, and we know it went a little wonky on that first one. Not bad. Good experience for sure. I felt very useful, if not a little overworked. But I like being useful, so it wasn't a terrible thing overall. But that's also, like, between me and you, that's a struggle that people are going to have transitioning from nurse to provider. As a nurse, you just run, you just do things. Your hands, you're just always moving. You're priming bags, you're pulling up medications, flicking the bubbles out, hanging antibiotics, listening to sounds. If there's downtime, you can do something. As a provider, you got to think about it. You have got to sit back for a minute and think, okay, we just went through all this information. Where does that put us? And what does treatment look like? Which doesn't feel currently as satisfying as just getting a bunch of shit done. So in my current clinical site, I am my preceptor's first student. She has been an NP for a year and a half, kind of going back and forth on whether or not she'd been an NP long enough to take on a student. And I'm having the opposite problem of my first clinical site. I don't feel like I'm doing anything. So at the first site, I had access to the charting system. I emailed, the whole setup was a little different. It was a smaller setup. I think that was a big part of it. It was a small private practice. So I met the owner. He introduced me to my preceptor. I met accounting. I met the front desk. I met I really don't know what her title was, that does like EHR support, but essentially maybe she was like billing and coding that also did EHR support. But I met her, and I had her email. I had everyone's email, and I said, hey, I'm the student. Can I get access to this charting system so I can start looking up these patients and drafting some progress notes and all this kind of stuff? And it happened pretty quickly. I had access within a week and a half of being at that site. So this site I'm at now, I started there for just 50 hours as a detox location, as a specialty. But between the sites that my preceptor works at, I was able to utilize her as inpatient as well. So we technically see patients at two different locations. They both use the same EHR, but they're obviously different, like they would be different setups. So I talked to my preceptor after I got her approved, like for the inpatient part of it. I talked to her about getting access, and she emailed the person who is most likely to be able to get me access. And she said, yeah, sure, that shouldn't be a problem, but they're implementing a new program at the site, so they're very busy. And then I kind of followed up in like a week. I said, hey, have we heard anything about that access? And she said, oh, you know what? I haven't. Let me email her back. And then she said, okay, yeah, give me her email address and her full name. and I'll get that process rolling. So we did that, and that was probably 3 weeks ago. And I have a week and a half left, and I don't have access. I cannot look up these patients. Not that we can anticipate who's coming in, because 99% of the time it is just walk-in. But even then, there are things to check. There are labs to check because we use Suboxone and Sublocade, and we have to check liver function. And unless I am staring over her shoulder at her computer, I am unable to kind of get the experience of checking that. We have to check the ORS report, which is the Ohio Prescription Drug Reporting System. I don't have access to that as a student. I think you need a DEA number to have access to that, but it's just another one of those things that you go through the process. Check the labs, check the ORS report, check the urine drug screen. These patients are required to drop or give urine samples twice a week. So check the urine drug screen to make sure there is an appropriate amount of the specific medications that they're on. Not too much, not too little. We're not diverting. We're not taking things we shouldn't be taking, which is something I could check as a student. And even things like certain demographics and medical history, their age would be handy. That's something that we do need to document. We don't have to document much in the Typhon system, but we do need age. Let's see, I just brought up Typhon now, so I need age, sex, race, some things that I can figure out for myself based on the encounter, and then other things like their diagnoses, which we don't always get to because some of the patients we see at these facilities are just for MAT, medication-assisted treatment refills. So we don't get the spectrum of what are they working with. Is it dual diagnosis? 90% of the time that's yes. What is their other diagnosis? What meds are they on? How does that possibly interfere with what we're doing, how we're treating? So I don't really get to see that. And my preceptor has seen a lot of these patients already. There's like 190 patients in the PHP, IOP, male group, and they just started a women's group. And I think their max is 12 currently, until they expand. So she has seen these patients. She knows that there are likely no interactions. We're just refilling the Suboxone. And as long as the ORS, the drug screen, and the labs check out, there you go. Less than a 5-minute appointment. So what I do like about this site is it is similar patients over and over. A lot of Suboxone, some Sublocade, a lot of comfort meds, clonidine. Are you having anxiety symptoms? Are you having nightmares? You have PTSD? You have trouble sleeping? We're going to start some trazodone. Is that working for you? Prazosin for the nightmares. And there's a whole system, there's a whole team working with these people. So they come in, they drop urine, they get a blood pressure, a full set of vitals, they get sent on back to medical and psych. We can basically see, like, are they stable? Because you don't always get to see that in an office setting unless you do it. Like a set of vitals. Is this affecting their blood pressure? Are they dizzy? How are they trending? Where did they come in? Where are they at now? So I can't chart anything because I don't have access. And my preceptor uses some AI tools. So the patients do sign certain releases when they enter into the program. And some of that applies to use of recordings for their sessions. So my preceptor uses, I think it's called Heidi. And it is, I don't know if you guys watch The Pit, but it's kind of like what Dr. Alashimi introduced to the residents on like one of the first episodes of the second season. Put your phone down, it records, and then she created a template of everything she needs specifically to chart for insurance reimbursement, like checking the ORS report, like asking the patient any thoughts of hurting yourself or others. Have you seen or heard anything that others can't see or hear? There are certain things that have to be checked off in order to meet requirements for insurance reimbursement and to support your diagnosis, your ICD-10. So she has a template set up. She does her interview, records it, spits it out into this perfect template document thing, and moves on to the next patient. Because she sees MAT patients or MAT patients, and a lot of those patients schedule their refills for like Monday. They don't schedule it, but just based on a nice routine, end up seeing her on Monday. Mondays, she can see like over 20 patients in her 7 to 8 hours that she's there, which is a massive amount. That's a lot of charting. So I do see absolutely how utilizing certain tools can make that easier. But as a student, I can verbalize the same questions she's verbalizing. I can ask you if you're having thoughts of harming yourself. But for the progress note, I'm kind of just on my own, typing out certain information into my computer without patient-specific details so I don't violate HIPAA, so I can have it for my type and documentation. But it's not quite the same as essentially working in this facility as a student. It's a little bit more observing, which has been a good experience. And I have very high expectations for myself, so I will never just sit back and relax. In my head, I am thinking, all right, a lot of these answers point to PTSD, nightmares. How is our sleep? Are we thinking prozocin? Are we thinking, do we have trauma-specific counselors in this building? We have one, and she's like booked. But in my head, thinking what that looks like as a provider for me specifically, I'm trying to make the most of it. Could I do more? Yes. Do I feel useless? 100%. I can't do anything with meds. I can't, if they're like, hey, because there's e-kits to pull from if patients are having immediate symptoms and they need relief. Their pills are at the housing, and we have an e-kit to give medications if somebody needs it acutely. I can't do anything with that because I don't work there. I'm not an employee. Plus, if you pull something from the e-kit, you have to fill out a paper to replace it, which basically consists of putting an order in, which I also cannot do because I'm not a provider. There's already somebody doing the vitals, which is not something I would be doing necessarily as a provider anyhow, especially in this specific situation. It's not what the providers do there. So if I'm looking to experience what they experience, that's not part of it. So that's kind of that with my current clinical placement. What I do like about it is that not everybody sees detox patients and Suboxone patients while they're in school. The director of the program, she does detox and substance use, and she said that she's seen a lot of providers come in and just have no clue where to start, what to look for, and essentially just have not had any insight into that world until they get there. So it is a good experience in that sense. I like that I'm getting exposed to it, and I see things to look out for and how to dose and how to titrate. So those are the positives. Plus, my preceptor is so nice. I do like that she's a more recent graduate. I got to pick her brain about studying for boards and getting through school and what her clinical experience was like. And we've also seen a handful of interesting cases together. In this population, some people have just used before they came in, like hours before, and some are not in their right frame of mind. And there are safety considerations that we have to take into account. So I've seen some pretty acute patients. All right, let's get back to my interview, my 50-minute interview with this doctor. I was her first student. She has been a doctor, I want to say for 18 years, and she's owned her own practice for approximately 5 years. She's the only provider at her practice. She's a one-man show, essentially. She does have a psychologist that she works with to help with some therapies, but she also does psychotherapies on her own. Like I said, she's trained in CBTI, and it sounds like maybe some other therapies as well. So in all of those years, she has never had a student, but she is so organized. She's so organized. She essentially said, we finally, after a couple back and forths, I felt like she kept expecting me to say something else or like more. She would just kind of stop and look at me, and I could ramble, but I don't think that's the right move. I have given you my answer, and I'm not going to just ask you, so do you want me as a student? That's your call. That's your call. If you have more questions for me, here I am. I'm not going to ramble through like I'm doing right now. Otherwise, she might diagnose me. So eventually we got to a point where she did say, okay, yeah, let's make this happen. What's your program look like? How many hours do you need? And because I am anticipating doing some hours with my personal PMHNP and some child and adolescent hours, I told her I would need 150 hours, and that would range from the first week of May to like the second week of August, with a lot of flexibility in between. I do have a PRN job. I can do it at whatever hours she needs, or once, or however it works out. We can knock them all out if we need to, or we can stretch it out where she sees me once or twice a week over a couple months. So she agreed to it. She said, yeah, sure, we can do 150 hours. And she started planning right away. She's like, when can you start? And I said, well, the first week of the semester, or the first day of the semester, is May 4th. And I think she said that her busiest days are Tuesdays and Thursdays, so that'd be the best place to start. And that she would have me observe for 2 weeks, and then following that, I would start getting hands-on. She said that she would have her IT guy install Epic, because she uses Epic, on my computer. So I can have access to the patients and their charts and their histories and allergies and medications. Everything that is very nice to know as a provider, which was great. I didn't even have to chase that. She is incorporating me a little bit from the bottom up, which I'm fine with. I'm not too good to do anything. So she said after I spend those 2 weeks seeing her flow, she'll have me start meeting the patients before her, getting the vitals myself so I can start talking to the patients as I grab those vitals and doing an initial intake, maybe doing some screening tools, PHQ-9s, and documenting them in the system. And then we'll kind of see how it goes from there. So she has a very solid start to how this is going to go, between access to the charting system, observation hours, starting to get your hands in, and then just working towards independence. So I really liked that. Despite the fact she has not had a student before, she has thought about, what is this going to look like in my practice as the only provider in this building in this practice. And I really like that organization. I like knowing that I have something that I'm building towards. I also asked her if she was the only provider. I said, do you have any partners? Is there anybody else that you work with? And she said that besides the psychologist, she does not have any partners, but she wouldn't be against hiring somebody like a psychiatric nurse practitioner in the future, as long as they were moldable and willing to learn more than just medication management. She's not a fan, it seems like, of just throwing medications at the problem. She wants to know, what is the base problem? Is it physiologic? Is it breathing? Is it sleep apnea? Is it sleep in general? Maybe from a trauma or something that can be treated with a little therapy. What does the whole patient look like before we start throwing meds at the problem? Which is kind of a cool thing for her to say as she's training me to her specifications. I'm going into every one of these clinicals as a possible job opportunity, trying to be as professional and friendly as I can be. And so far it's paid off. I'm on a couple PMHNP sites on Facebook, and I've seen a lot of people who are struggling to find that first job. And I don't know if it's because they have something in mind and they just want that, or if it's truly because the job search is hard. But if you use these opportunities, these clinicals, as an opportunity to meet nurse practitioners in the area and kind of get your name out there, there are PMHNPs that I know of that I've never met, because my preceptor liked me enough to refer me, to give me information or to give them information. Networking, it's all just a big networking game. So I hope that helps me, but I guess we'll see. Man, that was long-winded. I'm not even done. All right, one more thing. I got one more email from my school saying that there's another place that would possibly take me on as a student, and they also require an interview. And I had to wait for them to reach out to me. I said, so-and-so, the operations manager, will be contacting you to schedule your interview soon. And he did. He reached out and said, what day works for you? And I told him what day works for me. And now it's been approximately 1 week. It's been approximately 1 week and I haven't heard any kind of confirmation. So maybe I should email him again tonight. But if nothing else, I do believe I have my hours for the summer, which is so nice. It's so nice. These last 2 clinical semesters, I have started after the halfway point of the semester. I've crushed all of my hours into a couple months. I've been so busy doing homework, doing clinical hours, trying to fit in work. My manager is so tired of me not picking up the shifts she's asking of me. She doesn't say that, but I know she would be happier if I did pick them up. So the fact that this is a way more solid plan already going into this semester gives me so much hope that I can find balance in this last semester, which I'll need because I need to study for boards. Nobody tells you to study. They don't tell you to study, but things are coming to a close. Yeah, August. And apparently you can test before you finish. If you have all of your hours in, you can send a letter to somebody, the ANCC, I don't know. You can send a letter to somebody and you can test prior to, what do they call it? Conferment of the degree? I think that's what they call it. Apparently you can test prior to that. I don't know if that's something I want to look into or just let things play out and wait for my authorization to test and then schedule and do it the regular way. But if I could get caught up and do it early, because these semesters just roll right into each other. There's nearly no downtime between them, or between the spring and the summer, there's no downtime. It ends on a Friday, starts on a Monday. Between the summer and fall, I don't remember if there's a week or two, but fall semester starts the doctorate program. If I can have like a solid study plan and this test out of the way before I start the doctorate portion, I will be in a much better headspace to keep things rolling. So maybe I ought to look into that. Either way, things are rolling. Things are kind of on track right now, and I've got somebody lined up for the doctorate clinicals, and I'm just going to keep putting feelers out there. Even if I have to do extra, I don't think that's a bad thing, especially considering this current clinical site is slightly more hands-off than my first one. Even if I did extra hours, because they're more spread out, I can fit in extra. It doesn't say a max of 600 hours, a minimum of 600 hours. I would do that. I would do that for the experience. Did this video have any kind of purpose? Was I just rambling about clinicals? Did this help? Was this helpful at all? Very excited about the upcoming semester. We are just so close. Graduation commencement is 2 weeks away, which is going to be so much fun because that just makes everything so real and exciting. And I'll keep you updated along the journey. I don't know if you can peep it over here, but that is the gown and the hood. And there's a little stole right in the middle, and a cap. And I plan on putting a headband under that cap and seeing what we can do with it to make things a little bit more stable. All right, that's all I got. Thanks for hanging out with me and listening to me blab this whole time. And I'll see you next time. Bye.